So today's webinar is how can I be sure I'm doing the best for my patient with PGT-A? So quite an interesting question that brings together genetics, embryology and clinical practice, and consequently I'm delighted that we have a great panel today with a number of different speakers. So first of all, let me introduce Dr. Julia Gorodeckia. She trained in Obs and Gynae at Vilnius University in Lithuania. Has been in the UK since 2012, where she worked at the Whittington Hospital and then King's College as a clinical fellow. Her specialist interests are in pre-implantation genetics, advanced gynecological scanning, and early pregnancy diagnostics. And she's published a number of papers on this on these subjects. My next panelist is Mark Sedler. Mark I've known for many years, and he's one of Care Manchester's reproductive medical consultants and has been with Care for 12 years. Mark qualified and trained in Merseyside, where he was a clinical research fellow in reproductive medicine at the ACU at Leeds General Infirmary, and he's completed an Obs and Gynae training in the Yorkshire region. Mark, as I well know, since I've worked with him for quite a number of years, has extensive experiences in all areas of reproductive medicine, assisted conception and IVF. He's Manchester Care lead clinical for pre-implantation genetic testing. In 2012, Care Manchester had one of the country's first babies born using PGT, and been delighted to work with them since then. He also has experience in setting up supervision for patients with the specific requirements for the Orthodox Jewish community. Pretty interesting subspecialty. The third panelist is Oriel Alana. He's a state-registered clinical scientist and ESHRA certified senior embryologist. He's the deputy head of labs at the Fertility Partnership and laboratory manager at Boston Place Clinic in London. Oriel began his embryology career in Spain in 2006 before he completed his studies and training and moving to the UK. He's been in the UK since 2010 in London, part of the Boston Place team since 2014, and led the lab since 2017. He's contributed to international and national conferences, is an author, leads embryo biopsy workshops, and now is focused on PGT for the TFP program. So I am really looking forward to talking to our panelists after the presentations. But first of all, let me give you some of the background to this and tell you a little bit about what Cooper Surgical is doing. So PGT-A, let's talk just generally about PGT-A. So there's clearly three areas of PGT that you could consider. PGT-M, which is monogenic disease testing, PGT-SR, which is for translocations and chromosome abnormalities, but we'll talk today about PGT-A, which is testing for aneuploidies, and it screens embryo biopsies for chromosome abnormalities. Is it an option for all patients? Does it improve IVF success rates? These are some of the conversations that we'll have towards the end, and it doesn't require a personalized test prep. So if we think about PGT-A, the theory behind it is fairly simple. You have an embryo biopsy, you look to see if it has the right number of chromosomes, in this case 46 chromosomes, and then we think that it should have a better chance of ongoing pregnancy and live birth. If you find an embryo with the wrong number of chromosomes, in this case 47 chromosomes, then that embryo is less likely to implant, may miscarry, or if it's an extra copy of 13, 18, 21 or the sex chromosomes, it may cause a genetic disease. And in this instance, I've chosen a fairly straightforward situation because this is 47 chromosomes with the trisomy of chromosome 10, and there's never been a live birth of trisomy chromosome 10. So we know that that's not an embryo that we should select. Of course, things are more difficult and life is never so straightforward. And we have a third category of embryos now, and these are mosaic embryos. And this is where you have two cell lineages or more, euploid and aneuploid, mixed within the embryo. The case on the left here is where it is mosaic throughout the whole part of the embryo, and the case on the right is where it's only in the trophectoderm, the outer cell layers. And these give us more diagnostic and more embryological and clinical questions that we have to answer, and we're just beginning to collect the data for that area. We also have some excellent webinars on mosaicism, and here at Cooper Genomics we report embryos now in these different classifications. If they're euploid, so that is if they have all 46 chromosomes present and no others, or if they have less than 20% mosaicism, which is below our detection threshold. And then we have two levels of mosaicism reporting, low level and high level, and then once it's over 80% mosaicism, they're aneuploid. And the reason why we do this is we're trying to give the clinics an ability to rank embryos in where they might implant them first. Euploids clearly first, but then they might consider low-level mosaics before high-level mosaics. And this is just trying to aid the embryology and clinical practice. So here at Cooper, we've been trying to develop PGT technology for a number of years and have brought to the field a whole bunch of different technological innovations. And the first one that we did was that our means of analyzing embryos has changed. So we've been using AI for the past couple of years to do analysis of embryo biopsies. And one of the things that we did previously, you had to baseline all your IVF data in some way to say what is normal, and we used to use cell lines to baseline that data. And what we've gone on to is to actually take real data, live births and sustained pregnancy outcomes to baseline, and that's our truth data that we fed into the AI, and then we validated it using sequencing from 10,000 embryos. And this is trying to give non-subjective calling using stats, and also we automatically generate the results to take away human errors within transcription, etc. We've gone on and we now have the second generation of this AI platform, and it uses the same embryo biopsy truth data, but now we've been able to take advances of DNA sequencing. So we sequence more than 10 times than we did before, and 50 to 100 times more than other platforms. We also sequence in a more informative way, sequencing each DNA molecule from both ends. That's sequencing technology, but what it means is we can have two methods now to give you a PGTA result, both counting chromosomes using NGS, as we've been doing for the last 5 years, but also adding in inheritance information of SNPs. So you have two methods now for reporting any PGTA results. So the way we might think of it is we have our standard PGTA, and this is 2.0, and we get much cleaner data. So we have fewer no results. We have more resolution than we had before, so we can see things down to 5 megabases, and it improves our mosaicism calling. And this is now our standard test for all PGTA samples. So we have these two methods of analysis and this much better sequencing, but it also enables us to do other things. So if we can also take cheek brush swab DNA from mom and dad, because we have that inheritance information, we can do a number of different things, and this can be done at the time of testing or afterwards, and we can add in that parental DNA information. So you still get the best in class resolution, high sequencing depth, and mosaicism calling. But also we can now tell you other things like if there was aneuploidy, where that aneuploidy has come from. Is it from mum and dad? It'll give you triploidy and haploidy. So if the embryos had 23 chromosomes or 69 chromosomes and all forms of that, and that might have been missed by FERT check. The other thing it will also do is give you 2PN verification, and increasingly we're also looking at embryos that might have been 1PN or 3PN, and some of those have been 2PN after genetic testing. So just in summary, we have our two independent methods and more data is better for AI, and that's our standard test. But now we can add in ploidy, we can add in origin of aneuploidy testing and 2PN. And we have on our website in the webinar library information, a whole bunch of webinars, or you can go onto YouTube and find out more about PGT-A 2.0. And just to give you a little bit of data, so this is our latest data from 75,000 embryos, and roughly 40% of embryos were aneuploid, 44% were euploid, and 14% were mosaic. Really nicely, we have very low levels of no intact DNA, so amplification failed, and low levels of places where we couldn't interpret the data. So really useful, because we get as many results as possible from every biopsy. And also what we have is we have euploid rates that are similar and slightly higher than we had before, and then mosaicism calling. So overall, you're now looking at 58% of embryos where you could have a choice to whether to implant them either straightforwardly as euploid or as mosaics. So just in summary of our technology, where we are, we aim to improve IVF outcomes with PGTA. We are bringing advances in technology to give a more complete understanding of the embryo and the genetic content of the embryo. And hopefully with this, we can give you better choices and potential outcomes for the patients. So with that, what I would like to do is go on to introduce Julia Buldo-Licardia, who's going to give us a presentation that she provided earlier, and this presentation will be from her data at ASRM, and this is the clinical outcome of this PGT-A 2.0, actually how it's impacting patients and how it's working. Once Julia's presentation is finished, we will go on to the panel and we'll be looking for those questions. So please now, or when Julia's presentation is coming through, submit your questions and we'll get to them at the end. Thank you very much.
Hello everyone. My name is Julia Buldo-Licardi. I am a resident physician at Hackensack University Medical Center in New Jersey, and today I will be speaking about second-generation artificial intelligence technology for preimplantation genetic testing, also known as PGT, improving pregnancy outcomes in single-thawed euploid embryo transfer cycles, also known as STEAT. Thank you so very much for having me today. I have no disclosures. So our study evaluated whether the use of this technology improves discrimination between euploid, aneuploid, and mosaic embryos. And if it does, whether or not the use of this technology really improves those transfer clinical outcomes. This was a retrospective cohort study in a single university-based fertility center. Retrieval cycles utilizing preimplantation genetic testing and STEAT were analyzed from October 2018 to April 2020. Our primary outcomes included euploid rate, aneuploid rate, and simple mosaic rate. We started with over 24,000 biopsies. Of those, over 16,000 were analyzed by NGS or our control, over 4,000 by 1.0, and over 3,000 by 2.0. There are about 100 biopsies that were not included due to incomplete data. So this is a case distribution by age, illustrating that all of the age groups were well represented. When analyzing our primary outcomes, we looked at NGS versus 1.0, NGS versus 2.0. We used a two-tailed t-test for the analysis and considered anything less than 0.05 to be significant. Our first outcome was percent euploid. When looking at the graph, we can see NGS represented by dark blue, 1.0 by light blue, and 2.0 by green. Anything with a star indicates significance. So here we can see in the less than 35-year-old age group, almost all the way through the 41-year-old age group, a significant increase in the NGS versus the 1.0 and the NGS versus the 2.0. And when looking at our percent aneuploid, we can see in the less than 35-year-old age group, almost all the way through the 41-year-old age group, a significant decrease in percent aneuploid in the NGS versus the 1.0 and the NGS versus the 2.0. When looking at our simple mosaic, we see a decrease in NGS versus 1.0 and NGS versus 2.0 across the board, with significance being in the less than 35 age group all the way almost through the 40-year-old age group. It would be terrific if this technology allowed us to increase our euploid rate and decrease our aneuploid and mosaic rate. But are these changes just a result in the difference in definitions in the lab and the changes in the benchmarks? Or is it really improving diagnostic precision and accuracy and leading to improved clinical outcomes? So in order to investigate this, we looked at transfer and pregnancy outcomes as well. And our secondary outcomes included implantation rate, clinical pregnancy rate, biochemical pregnancy rate, spontaneous abortion rate, and ongoing pregnancy live birth rate. Here we can see a breakdown in the embryo transfers. We started with 1,174 single-thawed euploid embryo transfers. Of those, about 400 were in the NGS group, 580 in the 1.0 group, and 182 in the 2.0 group. There were about 5 transfers in each group that were eliminated due to incomplete data, ectopics, terminations, and heterotopics. When looking at our secondary outcomes, we looked at NGS versus 1.0, NGS versus 2.0. We used a Fisher's exact test for the analysis and considered anything less than 0.05 to be significant. When looking at our secondary outcomes, we found significant differences in the biochemical pregnancy rate and ongoing pregnancy rate, live birth rate categories, specifically in the NGS versus the 2.0 comparison. We found about a 7% significantly lower difference in the biochemical pregnancy rate between NGS and 2.0. NGS had a biochemical pregnancy rate of about 12%, and 2.0 had a rate of about 5%. When looking at our ongoing pregnancy live birth rate, we found about a 9% significantly higher difference in the 2.0 group versus the NGS group. The NGS group had a rate of 61%, and the 2.0 group with a rate of 70%. PGT-A 2.0 also displays an 8% difference in the clinical pregnancy rate when compared to NGS. Although this did not reach significance, it approached significance with P equaling 0.0534. It should also be noted that when comparing NGS to 1.0, there were similar trends in the biochemical pregnancy rate and ongoing pregnancy rate categories, but there were no significant findings. Overall, our group found that PGT-A increases euploid and decreases aneuploid and simple mosaic designations. We also found that embryos diagnosed as euploid via PGT-A 2.0 do have significantly higher ongoing live birth rates and significantly lower biochemical pregnancy rates than those assessed by NGS in STEAT. And finally, PGT-A 1.0 in STEAT did have similar trends as 2.0 in the biochemical pregnancy rate and ongoing pregnancy live birth rate, but without significance. We think this point is important because the 1.0 technology added the artificial intelligence and the 2.0 technology layered on the SNPs. So we do think it is a nice way to look at the data in a layered fashion to be able to appreciate the progress that Cooper has made while developing this technology. Limitations and looking ahead. This was, of course, a retrospective cohort study, and larger scale analysis is required to determine if next-generation artificial intelligence provides improved diagnostic precision, accuracy, and pregnancy outcomes. We did not adjust for uterine factor or history of multiple pregnancy loss in this study. And as far as looking ahead, our future studies will investigate the differences in triploid rate. This is the Prelude New York University Langone Fertility Center team. On the left, we have Dr. James Griffo. He is the Program Director, Division Director, and Chief Executive Physician of Inception Fertility. It is particularly exciting for me to work with him as he is a pioneer in PGT-A. In the center, we have Dr. Caroline McCaffery. She is the Embryology Laboratory Director. And on the right, we have Dr. David H. McCullough, who is the Assistant Laboratory Director. It is an absolute privilege to work with all three of these collaborators. These are our references, and I'm happy to take any questions at this time. Thank you so very much.
So I'd like to thank Julia for that excellent presentation. And now we're going to move on to the question and answer section of this webinar. I am Tony Gordon, the Vice President of Business Development here at Cooper Fertility and Genomic Solutions. I am a clinical cytogeneticist, and I will be the moderator for this, so hopefully I'll be able to get a good conversation going. No doubt with the people we have here, that won't be a problem. I'd also like to welcome my colleague, Lena Zogajai. Lena is our product manager for our genomics products, and she has been with us for 3.5 years at Cooper Genomics and has over 10 years experience in the industry. And if we get any product related questions, we'll go to Lena for that. But we do have questions. However, what I would say is we really appreciate that we'd like this to be interactive. We'd like to see your questions. So please feel free to put the questions into the chat box, and we'll try and take those questions in the next 30 or so minutes that we have for questions. But we do have some already, and the first question I'd like to go to Julia for, please. And it says, and then we'll go to Mark and Oriel as well for your views. Julia, the first question is, what are the typical indications you look for when considering offering PGT-A to your patients?
Well, Tony, this is a great question. I think the indications vary quite significantly. I think that one of the most common indications would be advanced maternal age, where you know that in any given IVF cycle, the embryos that are created, bigger proportion of them will be aneuploid and therefore will not be capable in resulting in successful ongoing pregnancy, and you want to get to the successful outcome quicker. Right, little bit less popular, a little bit sort of more specific indications would be situations where a couple, regardless of the maternal age, had experienced a series of traumatic miscarriages or terminations for chromosomal abnormalities, and they absolutely want to avoid repeating that experience again. One of the other indications, increasingly growing, at least in our clinic, is the surrogacy treatment, where we face a difficulty in retaining the surrogate for that particular couple. And obviously, she would not want to undergo multiple embryo transfers with questionable outcome. And therefore, the intention is to make sure that when she has an embryo transfer, she gets pregnant and she stays pregnant successfully. So I think that those would be one of the key indications, but obviously, sometimes it's a patient choice as well, and we have quite an extensive conversations about whether the particular couple is likely to benefit from technology or not.
Thanks very much, Julia. Oriel, maybe we can go to you, and then we'll go to Mark, if that's fine. Oriel.
Yeah, in an ideal world, what you would like is to transfer a euploid embryo and have very little chance of this to miscarry. No, so you would like a successful outcome. So any patient that could benefit from that would probably be a good candidate for PGT-A. So in the same line that Julia was saying, advanced maternal age, for example, is a reason why we would recommend PGTA, previous miscarriages. But also, sometimes you get patients that have or had one or two failed transfers, and they still have a large number of embryos in storage that are not tested. So we also offer them the possibility to test these frozen embryos in a way that you can shorten the time that it takes for you to reach a pregnancy.
Thanks very much, Oriel. Mark, over to you.
Thank you, Tony, and thank you for those comments. I absolutely agree with my two esteemed colleagues. The whole idea of fertility medicine, in my opinion, is to achieve live birth in the speediest time with the minimal trauma to grow a family. And that's why all those indications that have just been proposed are very, very valid. Other things that I think apart from that, one of the things that I tend to do is many of the couples receiving or the ladies receiving donor eggs are clearly in the older age category. And some of them are developing certain conditions. And of course, what you ultimately want is a healthy mother and a healthy pregnancy. So although some people think it's a bit contentious, the screening using aneuploidy screening for embryos through donor eggs gives couples the opportunity. You know, if someone's 48, they don't want to wait till they're 52 before they actually achieve a pregnancy, etc., etc. So there's so many good reasons, as Julia and Ariel have just explained, all of those reasons, and very much so with the frozen embryos. You often get couples who've got a young child, they've got 5 or 6 embryos. They may actually be quite young, but what they don't want is to get pregnant, say have a miscarriage, and all the trauma of that while they're looking after another youngster. So there are so many benefits, and all of those would cover.
Yeah, thanks, Mark. Some great answers there, and clearly lots to consider for patients as they're coming in. We do have a question that's come through on the Q&A for Lena, and please, if you would like to submit your questions, it's great to see them coming through, and send them into the chat box. The question for you, Lena, was how do you explain the increase in live births using the PGTA 2.0 technology?
Thanks, Tony. That's a really good question, and I think it's really for a number of reasons. One of the main things are some of the points that you mentioned in your presentation, Tony, on how this algorithm or AI that we utilize to analyze genomic data, how it was developed. First and foremost, it's been developed utilizing real embryo data that we know led to an actual baby or ongoing pregnancy. So for that, we've established what we know and consider as truth data or a verified baseline. So when we are reporting euploid embryos, we are certain that they are unequivocally euploid. And then, of course, getting away from the limitation of subjective interpretation, which is really a big thing and something that's often discussed in a lot of the congresses around the world, the limitation of subjective interpretation and having user-to-user bias. So moving away from that and its true fundamental development with real-world outcome data, I think really sets it apart and has contributed to this improvement in positive obstetric outcomes.
Okay, thanks very much, Lena. So I have another question. The question was kind of inevitable because it is the hot topic of the day in our world, and because it's quite an embryology-focused question, we'll go to Oriel first, and then we'll go to Julia and Mark again. So Oriel, mosaic embryos. What's your clinic's policy on the transfer of mosaic embryos? And as a little follow-up question, which is a little bit different, but has come through on the live stream, what's your policy on the transfer of aneuploid embryos? I think the second question will be a lot easier to answer than the first, but Oriel, please, what's your policy? Starting from the easy answer, for aneuploid embryos, we don't transfer them. When you think about it, is why would you do PGT-A at all if you want to transfer these kind of embryos? Also, I'm afraid I cannot remember the author. I'm sure you will, Tony, but there is a recent study where a randomized control study, double-blinded, where all embryos transferred that were aneuploid lead to nothing, which kind of reassures you that it's not a good idea to transfer an aneuploid embryo. Yeah. Teague et al., the non-selection study. Yeah, indeed. In terms of the mosaic embryos, at the beginning, it was more difficult probably to make a decision about what to do with these kind of embryos. Our policy, now that we can split them between low level and high level, is that if the patient has proper counseling and the patient is making a fully informed decision, they can transfer a low-level mosaic. The recent numbers that we've seen suggest that it's not that bad idea. There's livers with this kind of embryos. In terms of the high-level mosaics, we are still not transferring them, or at least we are not recommending the transfer. But we are discussing it more because now we can split mosaic embryos within about 8 categories, I would say, high level, low level, but then segmental, 1 chromosome involved, 2 chromosome involved, etc. And there's quite of a categorization that you can think of. So really, if you land in a category that's a very low chance of a live birth, probably would advise not to transfer. But again, if the patient is fully counseled and they are aware of the potential outcomes, it can be discussed. Excellent. I mean, it's clearly, a very difficult issue to grasp, pretty complex when you have all these different sort of shades of grey. So yeah, really interesting to hear that. Julia, what's your clinic's policy on mosaic embryos?
I think, Tony, as your side of the technology and knowledge is evolving, so does our approach to transfer of those embryos had evolved with time. And I think that once initially we've started getting the reports of the mosaic embryos, we were quite cautious and quite worried to put those embryos back, because once you know something about the embryo, you cannot unknow that, and the whole weight of knowledge makes things a little bit more complicated. With time and with our experience and with more publications coming around and with patients groups being more active towards transferring mosaic embryos, I think that we became more confident that low-level mosaics can result in live birth and in healthy live birth. And so low-level mosaics are the ones that we do transfer, and we discuss that with patients. Again, it depends on which chromosome is involved, and some conversations are more extended than others, because obviously some chromosomes can lead to mosaic chromosomal changes can lead to certain problems in the future, and we have a full in-house genetic counseling service to cover for that. With high-level mosaics, we're not there yet. However, the conversations have started because, why not? Mosaics means that some of the cells are euploid. If some of the cells are normal, then maybe, again, with the proper informed consent, you could consider putting them back. We have not been in that situation yet, but I think it's just a matter of time. And now on that continuum, aneuploid embryos is the tail end of it. And I agree with Oriel, why do PGT-A if you, at the end of the day, regardless of the outcome, you want to put those embryos back. But again, you need to respect patients' autonomy. And I think that at the end of the day, without genetic testing, you would put those embryos back. They're equally good for transfer. With genetic testing is that piece of knowledge that stirs those conversations. Again, we have not been in a position of patients requesting aneuploid embryo transfer, but I think we'll reach that point yet, and we'll cross that bridge when we get there.
Okay, thanks very much, Julia. Mark, over to you.
So I'll start with the mosaic situation. So we do, and we have had live birth from certain mosaic transfers through our clinic, Tony. The important thing is CARE as a group have collated a lot of data regarding the specific mosaics that have been transferred kind of through worldwide laboratories and clinics and the outcomes. So we have quite a specific counselling regime regarding which mosaics we still would not put back, which mosaics that you could consider, and which mosaics whereby there's never been a child born with a chromosomal anomaly from that mosaicism. But the counselling is very important because it's important to tell the patients that irrespective of the ones we put back, the overall implantation, sustained, ongoing, is less and the miscarriage rate is higher. So I think in summary for that is if you select cautiously and with appropriate data and counselling the correct embryos, they of course do give a chance to live birth. And as my colleagues have said, you do put embryos back all the time that you don't know what they are in clinics who have never done PGT-A. So that's on the mosaics. As far as the aneuploids, we are not allowed to put any true aneuploid embryos back. And I think that non-selection study that you've alluded to is a very good study because ostensibly what that suggested was if you put an aneuploid embryo back, the live birth data is 0. And if you put a euploid embryo back, 2/3 are live birth data. So that's pretty conclusive. The one thing that we've had discussions about this is aneuploidies that can lead to live birth, such as trisomy 21. That is something that is, I think, should be discussed more, and I think there should be opportunities for patients to consider those transfers after the appropriate counselling.
Yeah, it's a tricky subject, certainly for those live birth ones. Yeah, absolutely. So I think, interestingly, well, possibly disappointing for the discussion, but you all seem to agree. You have very similar policies, and it's great to hear that you have, transfers and live births after mosaic transfers, because it kind of justifies the work that we're doing to try and identify those mosaic transfers rather than, call them aneuploid as we might have done in the past. So that's really good. So I have another question that's come through. I'll go to Oriel first because it's, again, a little bit more on the embryology side, then go to Mark and Julia. So it says there have been discussions, and there certainly have been discussions, on the potential damage to embryos through biopsy procedures. How do you address those concerns, Oriel?
Yeah, over the years, you realize that the most important thing is that the patient has to be fully aware about what's happening in the lab and what's happening with their embryos. Now, if you have to explain after the procedure that the embryo has not survived the biopsy or the freezing or the thawing, that's never a good conversation. But if you have explained, you have given the information to the patient beforehand, and you explain any potential outcome from those techniques, obviously at the first instant they would hesitate because it's a precious material and they don't want it harmed. But when you put the numbers on the table and the reality is that an embryo should not be harmed from a biopsy, that reassures them that there's no risk of biopsying an embryo.
Thanks, Oriel. I think there's also a certain element, and you're probably too shy to say this, that you need to be an expert embryologist as well, like you guys are, and you need training and those sort of things to be competent. And I think, you guys get great embryology practice.
PGT, the problem with when people talks about PGT is that it tends to be focused on the outcome, euploid and aneuploid mosaic, but it's actually a multidisciplinary process. You need a very good cryopreservation program. You need a good culture system as well, because without blastocysts you won't go anywhere. You need a good biopsy technique, tubing as well. So it's a whole chain of processes that need to work together very well. Absolutely,
and obviously, we as the genetics lab just get that tube with hopefully some cells in it, but we try and work with you guys, to be part of the whole process, because it is a team effort to get there. Absolutely. So, yeah, absolutely. Mark, over to you. How do you address the concern of biopsies for patients?
Yeah, I mean, this is an interesting one, because that is one of the biggest concerns, actually, because as Oriel has explained, these are exceptionally precious commodities, as they've said, and they don't want anything to happen to them. So the way I kind of explain things is, number one, because we've been doing this for over 10 years now, we do have huge amounts of data. And the actual chance in our laboratory of an embryo perishing from the procedure is 1 in 200. So that's remarkably low when you think. I mean, I can't still get my head around it, considering what you're actually doing at the procedure to something so delicate. So when I tell them that, obviously it does, allay some of their fears. The other thing I sometimes say to them is, and which I think is important, is we don't really tell them when we do ICSI what the chance of the egg perishing from the ICSI procedure is, which is still very, very low. And I think it's because the biopsy seems now to be such a, people get it in the head, how can you take cells from something so small without damaging it? So generally I reassure. I also say that if the embryo survives, which the majority do, and it is euploid, then the thaw rate is over 98.5%. In other words, if you add up cumulatively the total risk of an embryo going through biopsy, not surviving the thaw, it's literally at most 1 to 2%. Whereas, of course, across the board, even in a young fertile woman, half of all embryos are abnormal anyhow. So that's the way I kind of explain it to patients, to give them some real grasp on very, 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 very low risk, although it's not necessarily no risk, versus half of all embryos as a minimum not leading to ongoing pregnancy, and worse still, leading to things like miscarriage.
Interesting. Yeah, it's interesting to get that context. Yeah, it makes it a lot clearer that way. Julia, over to you.
Yes, well, I think that I'm always cautious commenting on what's happening on the embryology side, right? Because I'm not directly involved in that. So it's always a very delicate conversation not to overstep my boundaries of knowledge and expertise. But I think that inevitably those conversations do happen almost with every couple. And the position and the way that I address this question is by talking about, first of all, as I said, not everyone is going to benefit PGT-A technology to start with. So we're talking about couples or patients who do have a good number of embryos to start with. If that is the case, then obviously a bigger proportion of the embryos, even if you do a fresh transfer, will be frozen for future use, right? And then when we talk about the embryos being frozen anyway and having to undergo the thaw anyway, with or without genetic testing, granted, those things do happen. That's not a very common event of embryos not surviving the thaw. But then I give our lab statistics to say that with or without biopsy, I think survival rate is very similar, which gives a reassurance that if embryo is not surviving the thaw, it's probably not the biopsy. It's just something that doesn't allow that embryo to undergo such a stress. And that gives a lot of reassurance to patients as well.
Yeah, I think it's really interesting to get the facts, because it is such a difficult process for patients. We have a quick question for Lena, and then we'll come back to the rest of the panel because it's another sort of product-related question. It's Lena, with PGTI 2.0, you use SNPs. Will this replace PGT-M?
Yeah, it's a good question. Certainly, we're always looking to evolve and innovate our technologies, and that applies to PGT-M as well. Currently, as you know, and most of our users know, that we utilize NGS and SNPs specifically for PGT-A currently. But in the future, we do foresee that utilizing not just SNPs, but also an NGS-based technology for PGT-M is the direction where we want to be headed and innovate the way we currently conduct PGT-M testing.
Thanks, Lena. So much like we probably would never get away without a set of questions talking about mosaicism, the other thing that we'll never get away with without talking about PGTA and asking some UK clinics is the traffic light system. So before I'll go to Mark and then Julia and then Oriel, but before I go, I will just give a brief introduction to what the traffic light system is for people who are outside the UK who don't know. So in the UK, we are regulated by the Human Fertility and Embryology Authority, which is a legal body, and they make recommendations on treatments and treatment add-ons, as they call it, and PGTA is an add-on. And then they look for things like high-level, large amounts of randomized controlled trial data to support decisions of whether they recommend it or not. At the moment, I'd say, I think it's reasonable to say slightly controversially, PGTA is a red traffic light. So in the UK as well, just to explain, our traffic lights have 3 colors. You could explain that as well. We have green, amber, and red. So it's at the bottom of the light at the moment. So the question that came through was, and we had a few questions on this in themes through the questions. And please, if you have a question, submit it. It says, PGTA is traffic light red according to HFEA guidance. How do you discuss the HFEA traffic light red with your patients? Mark?
Okay, thanks, Tony. I mean, this is one of the biggest issues I have in particular, Tony, with patients coming through on NHS treatment, because they're not actually even allowed to pay for PGT. The reality is, if you look at what the HFEA say, their statement is this technology does not increase live birth, which is wrong. But I understand what they're saying. What the HFEA is saying is you have a batch of embryos for a couple, keep putting them back, and eventually you will get to the normal ones, and eventually you'll have a live birth. Well, that's all very well and good, but what that doesn't do is address all the other issues regarding fertility treatments and pregnancy. So that's not addressing the fact that many couples take years to get to that point. Many couples have numerous miscarriages with all the physical, the emotional trauma of that. You can save valuable reproductive time, the cost effectiveness of minimizing transfers. So what you have to look at is all of these other things, not just the fact that, yes, live birth data. And I would have to be honest, in my opinion, the idea of PGTA is you are excluding the embryos that will not have a reproductive potential to normal live birth. And in that respect, if you look at the HFEA, they're correct regarding the live birth data. But I can give you many examples, I'll just give you two quick examples. This is one that maybe no one's ever thought of before. I had a patient who tried to commit suicide 3 times because she'd had so many miscarriages. And she came to the clinic and she was in an awful state. She had 2 cryopreserved embryos. And she didn't think you could test at that point frozen embryos. And when I told her she could test them, the relief that you could see with her, even if they were both abnormal, she would have been pleased because she would not have suffered the horrific experience of miscarriage. And funnily enough, if you look at the HFEA, they actually say these add-ons you can actually use for other indications, if appropriate, for things like miscarriage. So you have to look at what the HFEA are actually saying. The other thing I would say is I'm not convinced the HFEA, because they put that you have to have at least one randomized controlled trial, good quality, to say that at least you could give it the go-ahead. Now, I don't know what the HFEA have been looking at, but they say there are no trials whatsoever. And that is wrong, as we know. There's been many studies and trials, and the majority of them show a benefit to ongoing pregnancy to live birth and reduction in miscarriage. So I go through all of this with the couples, and I have to be honest with you, the majority of couples, after I've discussed this with them, they're in absolute agreement. But I do understand where the HFEA are coming from.
Yeah, I think it's fair to say that the data is not universally positive, because there's been a number of trials that use old technology or are doing polar bodies and things like that. So there's a small data set for positive trials, but they certainly are there. So I think I would certainly agree with you. Julia, over to you. Julia, no. So maybe we'll go to Oriel. Oriel.
Yes, I don't think I'm going to be as controversial as Mark has been. But yes, so the HFEA traffic light, I think it's quite of a necessary thing for the patients to have an independent view on all these treatments. We are very transparent. We tell them that this is the situation. It's on the paperwork that they get when they go through PGT or PGT-A. But at the same time, when you, again, that's a game of numbers. when you tell them their chances of having a baby with a euploid embryo, well, there's no discussion, especially with advanced maternal age. Obviously, the challenge is to get this euploid embryo, but once you get it, the chances for this to work is very high, and you don't see this kind of results on groups of age without advanced maternal age without PGT. So it's there. It's a red light. We inform the patients about it, but at the same time, our data suggests that we are not doing something wrong, really. We are helping the patient by recommending them to use it.
Thanks, Oriol. Julia, are you there now?
Yes, I am.
Thank you.
All right. Yeah, so I think that, again, I'm not going to be controversial. We do discuss that. We're very lucky that our patient population is so well educated that quite often the traffic light system is brought into conversation by patients before I even get to that question. So I think that our patients are very well read and they're very well educated, and quite often they do read the published articles as well. So it's a very interesting conversations on the levels of evidence that is there and what lays the basis for HFEA decision. I think it is quite right, and we all agree to the beginning of the conversation that not everyone is going to benefit from the technology, and I think that's part of the conversation as well. And in that perspective, we're not controversial to HFEA position as to say that probably is not a suitable approach as a blank policy across the whole clinic. And this is what we see in our practice. Recently, very interestingly, I spent more time talking patients out of PGTA than presenting the potential benefits, because quite often patients have a misconception that PGTA makes somehow embryos better, which is not true. I think that to second Mark's position, in theory, those embryos are exactly the same. You carry on putting them back. If there is a euploid, it's going to implant. In practice, if you have a sort of far advanced second trimester pregnancy loss or termination that damages the uterine cavity, that inevitably changes the whole game set for any further prospective embryo transfers. And I think that is one of the other arguments to keep in mind, that those embryos transfers, subsequent ones, are not equal one to another, because one embryo transfer with unfortunate outcome can lead to certain consequences that the couple was not facing at the very beginning, and obviously the trauma and all that. So I think that those conversations are there with every single couple. PGTA is embryo selection tool. It is a very powerful selection tool. Nothing else in reproductive medicine gives as high embryo success rates per embryo transferred as euploid embryos. We all agree on that. But in order to benefit from that, you need to have a number of the embryos to select from, because if you only have one, with or without testing, the result is going to be the same.
Yeah, I completely agree with you there, Julia. And I'll just put a little plug for Fertility 2021, where we have a symposium on the 8th of January at 8 a.m. And we have Professor Darren Griffin from the University of Kent. And Darren has been doing a study of the HFEA live birth rate per embryo transfer and per treatment cycle, and he'll be presenting that data at Fertility 2021 at our symposium. I think it's a pretty interesting data set when you actually look at the HFEA's numbers. So I think we probably have time for maybe one last question. We might try and sneak another one in, but this one will go to Oriol first, and then Julia, and then Mark. And it's a kind of two-part question. So it says, with any test, you can get unexpected results, such as no results, or all embryos aneuploid. How do you, as a clinic, manage PGTA where you have these negative outcomes? I think, Oriol, when it's talking about no results, I'd say, do you rebiopsy embryos? So, Oriol, over to you.
Yeah, this is again managing the expectations of the patient beforehand. They need to know that no result is a possibility. Good news is that with PGT-A 2.0 now we get less no results, which is fantastic, but still can happen. And then in terms of what to do with a no result, to me, it really depends on the embryo quality. We do biopsy almost every blastocyst. It wouldn't be a very poor quality blastocyst for us not to biopsy it. And then if you biopsy with the Gardner system, if you biopsy in grade A or B trophectoderm, I would certainly rebiopsy it again. But if it's a poor quality embryo that you think you might damage it by taking some more cells, then I would probably not recommend a rebiopsy. And then it really depends on the counseling afterwards, if the patient decides to transfer it as a non-PGT embryo or go for a different cycle, in the event that this is the only option that you get or you have at the end of the test.
Thanks very much, Oriol. We are collecting rebiopsy data, and I think it's going to be really interesting to look at that rebiopsy data. Hopefully, we'll be able to do another webinar in the future with our rebiopsy data, which I'm glad to say all your clinics have contributed to, so it's an interesting data set. Julia, over to you, and then finally we'll go with Mark, and this is going to be our last question, unfortunately. Julia.
Well, I think that with the no results, I'm very pleased to see that doesn't happen very often. And usually in the cohort of tested embryos, you have something else to work with. So you kind of can go back to this question a little bit later. However, if that is the only embryo and the couple is not in a position of repeating a treatment cycle, then obviously the conversation is the same as Oriol said, either rebiopsy it. Quite often we do get a result, and we get euploid result, and couples are very happy. Alternatively, you can treat that embryo as untested and put it back without further additional information. That is a subject of a conversation. Now, talking about aneuploid embryos, in all honesty, once you've been in this area, in this field for a couple of years, very rarely you get a completely unexpected result. You normally know which couples are under higher risk of having no euploid embryos. You discuss that up front. That's part and parcel of informed consent to say with PGT-A, inevitably you will have less embryos to transfer, and you will be in a position, and you can be in a position where all of the embryos are abnormal. We use this data also to inform the patients and to have a little bit more informed discussion as to what are the likelihoods of repeating a treatment cycle and getting a euploid embryo. Because obviously, if you have a group of embryos where each embryo have a single chromosome disorder and those chromosomes are different, the chances are slightly different to multiple chromosomal abnormalities in all embryos as well. And that helps patients to maybe change the take on the reproductive options and maybe make a decision quicker to move down towards donor X. And again, we have very open discussion with patients about that.
Thanks, Julia. Last word to you, Mark. What's your view on this?
Yeah, I'm just unmuting. Can you see me?
Yes. Yeah.
Yeah. So on the question of all, say, aneuploid, I always discuss with patients there is a relatively high risk that all tested embryos can be abnormal and therefore no transfer. But what I tried to do in the initial consultation is explain to them that if that was the case, then there is a massive benefit of no embryo transfer for all the other reasons we've discussed: the time to the next pregnancy potentially, the reduction in miscarriage, etc., etc. So if they're warned about these things, it does come as less of a shock. But irrespective of that, virtually all patients, whatever you tell them, are expecting something normal. Of course, it's very disappointing if there isn't. I agree with Julia that what I tend to say to patients is you have to look within a couple of cycles of finding euploid embryos, because you're not going to get euploid on every one cycle. And also that argument about if couples have 2-3 cycles and they're all aneuploid and there may be multiple aneuploidy, then obviously that may solidify in the couple's minds, yes, let's move on to something like donor, which maybe they wouldn't have done before knowing that data. As far as the no results, we were testing no results, Tony, I think with you back in the day, years ago. We tended to find that, I found that about 80% on retesting were aneuploid. So we used to kind of say, well, if it's a no result, it's more likely to be because it's poorer genetic material, etc. Therefore, it's not going to be a viable embryo. But I think as technology's improved, then I think that's slightly different. And I agree with Oriel that you have to speak to as a clinician, the embryologist, to say, look, will this embryo, has it the potential to survive a further thaw, biopsy, freeze, rethaw if it's euploid? So there's all those aspects to it. Just one actual anecdotal. I have a card in my room from a patient who'd had recurrent miscarriage and she had one embryo left, and she would not transfer it unless she knew the ploidy status for the obvious reasons. And it took 3 thaws and 3 rebiopsies because for some reason there wasn't just enough genetic material, believe it or not. And on the 3rd thaw biopsy and then subsequent, because it was euploid, she had a normal live birth. So that does show you that testing no results can lead to a positive outcome.
Well, thanks very much, Mark. And it's lovely to finish on such an uplifting story, actually. It really is. I would just like to thank Julia, Oriel, and Mark. As ever, we could talk all evening on this stuff. Fascinating to hear your actual, practical views on this subject. And just like to thank you for contributing to this webinar.